Hello, everybody. Good afternoon. I hope your attention span is still working. My name is Hans Ossebaard. I'm from the Netherlands. I just escaped a big influenza epidemic about a week ago. And while away yesterday evening, the Minister of Foreign Affairs stepped down. So you can't be away too long from this country. I'm here to share with you a few lessons and experiences I've learned, and I hope this will be of interest of you. I shall first introduce myself a little. I have several professional affiliations. One is at the moment with a big organization, VVAA, servicing about 120,000 healthcare professionals in the Netherlands. They are dentists, medical specialists, doctors, pharmacists, and we serve them with advice with regard to insurances, HRM questions, and also recently, that's what I do, advice with regard to eHealth and healthcare innovation. I'm also related, which is actually my main job, to the National Healthcare Institute, which is an independent government organization in the Netherlands. We have several legal statutory tasks. One is that we advise the Ministry of Health with regard to the content of the basic healthcare insurance package. I'm sure in Finland you have something like that. We force our free citizens to pay an amount of money for their healthcare insurance. It's a kind of social insurance. To balance out this obligation, the government is obliged to see that the care that you pay for is good care. Is not more care than necessary, is not less care than necessary. It's not more expensive than necessary, it's not cheaper than necessary, it's good care. So that's the motto of this institute, taking care of good care. This is highly sensitive, as you can imagine, because health and healthcare is a very sensitive, emotional subject for all citizens. Another statutory obligation concerns the quality of healthcare in the Netherlands. We have to facilitate that all stakeholders in healthcare, patients, healthcare professionals, insurers who play a central role in our system, together they have to decide what is good care with regard to a leg operation or whatever. The government cannot decide what is good care. That's what the professionals do, and they lay it down in quality standards. Okay, my job at the Institute is to see to it that if effective e-health is there, it is embedded in the quality standards. Okay, and the third task regards the question of what we should do. I'm sure in your country the same issues play. What should we do now to educate our young professionals, our young people, to be ready for the healthcare demand in 2030? What should we do now? We have in the Netherlands 2,300 healthcare professions. Incredible. We have about 150 different healthcare educations. Well, in this jungle, there should become some bright spots, so to say. Okay, a third affiliation is with the University of Twente. We cooperate with the university in Oulu. I do research there and publish and am lecturing, mostly with regard to what we call persuasive technology. To coach implementations, in eHealth there's a lot of dropout, both of patients and others who after a while stop using the specific application. Okay, innovation in care. In all these three roles, in practice, in science and in policy, of course I encounter innovation. Innovation is a kind of a value-free word. Nobody can be against innovation. And it's the association with innovation is positive, it's optimistic. And when we see at the beginning of the year what are the trending topics in health with regard to what's coming to us, these are positive connotations of sustainability, of artificial intelligence being there for good, data analytics, businesses who miss out on this transition to digital will miss out for good. Well, we all like these lists, and they're made by Forbes or other big consultancy companies, and they can be, some more future prognosis can be added with regard to the blockchain, to edge computing, to the 5G mobile technology, etc. You already recognize this. So this has all to do with innovation, the positive, optimistic connotation for innovation. But innovating healthcare is hard work. Everybody who's been in health for some time knows that. We know there's a lot of techno-optimism, techno-utopism, I sometimes call it, hoping that technology will save us from aging, from rising expenditures, from other problems that we have in our society. It's hard to make business models in health because the healthcare, I'm sure in Finland is the same, it is not an ordinary market. It's a heavily regulated, compartmentalized market. And at the end of the day, innovation does not always equal quality improvement. This is what it should be. In the Netherlands, actually, we have an open system for innovation. When we speak of innovation, we speak of product innovation. We have seen some beautiful examples today and yesterday. Product innovations are generally not so much the problem. There's also an innovation in terms of processes, changing processes, transforming processes. It's never about the technology itself. It is always about the people who have to work with these technologies. That's why we call them enabling technologies. They enable different behaviors. They enable a different way of thinking about healthcare delivery. For an innovation to be paid by collective means in the Netherlands, for an innovation that lands in the basic healthcare insurance package, the knockout criterion is actually that it should be effective. This new form of care should be at least more effective than doing nothing, or at least more effective than care as usual. Okay, also it should be necessary, it should be feasible, it should be cost effective. It should not cost more than current care does. But the knockout criterion, of course, is effectiveness. That has to do with solidarity. Solidarity and safety in the healthcare system are actually very important principles. I can only convince you to pay for my costs that you don't have yourself, or maybe will never have, if you are convinced by that the intervention, the treatment I get, is effective. Okay, in the West, we decide effectiveness by scientific methods, evidence-based medicine, we call it in our health. Of course, not everything can be measured by evidence-based medicine, but it's our allusion to the truth, so to say. So that's why for innovation, the scientific associations of medical specialists are very important stakeholders. They should take their role and get new innovations in which they believe on the ground in experimental spaces, in innovative spaces, and collect evidence. In the Netherlands, I'm not sure if you have that in Finland, when an innovation is so interesting that we have many people who believe in it, professionals, patients, insurers, but there's not enough data yet, we say, okay, we put it in a conditional, we finance it conditional. We say it's insured care from collective means for 4 years. And in these 4 years, you collect this evidence in an acceptable scientific way. And then we see if we advise that this innovation will be there for good. And not only there for good, but it should actually also be a substitution for care that is there. Okay. To illustrate these kind of issues with innovation, I will speak a little on the case of eHealth in the Netherlands. eHealth is always an innovation. Innovation is not always e-health, by the way. Innovation can be very low-tech or no-tech or processorial. But in the case of eHealth, we have some things I would like to share with you. Maybe they can be recognized by you too. eHealth is a container concept like innovation is. You should always make clear what you mean. I always do that according to 3 axes. Who is actually the end user? Maybe a doctor or a professional, maybe a patient. What actually is this specific technology we're talking about? Sensor technology, VR, a simple iPad, and in which care context is it taking place? So the container concept of eHealth becomes more clear when you say, well, okay, it's an elderly patient in home care using an iPad to communicate with a healthcare professional. Okay. A vague concept of eHealth also belongs to young science of eHealth. It's a very multidisciplinary, cross-cutting way of thinking about different forms of healthcare organization, healthcare delivery. eHealth is always health. And we speak about, well, you know these kind of things. Of course, in the primary process, that is for us here maybe the most interesting thing. For business, of course, the secondary process, which is below the immediate treatment between doctors and patients, is also interesting. You cannot imagine modern healthcare without ICT systems with regard to finance, administration, the delivery of quality indicators, procurement, planning, etc. You cannot do that without ICT. When we speak about the primary process, is the direct treatment. This has other legal frames below it, as you can imagine. Legal frames because I, as a doctor, you as a patient, or the other way around, we have different legal roles in that respect. This is also with regard to the technology you use. And these enabling technologies, they regard the communication process between doctors, intercollegial consults, between patients, the whole 2.0 web, enabling, uploading, communication, sharing of experiences. 20 years ago, if somebody had a rare disease, the chance of meeting somebody else with a rare disease was almost 0. Now you're 2 clicks away from somebody in Brazil or the Ukraine, sharing experience on how to, how you have to deal with your sickness. Okay, the urgencies, we've been speaking about them yesterday and today also. We share the urgencies, I think, almost everywhere in the world. We have a changing demography. A changing demography means, in our case, elderly people who have different needs, and we have to respond in our healthcare system to these different needs. Our life expectancies increase. We live longer. We don't die so easily of a disease. A lethal disease yesterday is a chronic disease today. We can live with this chronic disease. We can live with 2 chronic diseases. Comorbidity, 3 diseases, probably with the help of technology. In the Netherlands, but also internationally, a different health concept is evolving. Health is more and more defined as the ability to deal with physical, social, spiritual, emotional disadvantage. The extent to which you are capable of dealing, of coping with bad luck, defines your health. So not so much your sickness is central, but your functioning. For instance, people having reuma can function very well on medication. So it's not so much your sickness. This is also pressing on the healthcare system. And we have bigger transitions, like the title of an editorial in the BMJ a few years ago was "Healthcare is going home." And that's what's happening. More and more self-management is taking place. Hospitals, smart hospitals, are so smart that they do not longer invest in bricks but in bites. New hospitals in the Netherlands, they decrease. They invest not in growth, they invest in reduction. Okay, I'm sure you recognize these urgencies, these international urgencies. Did I miss something? Okay. The expectancies have been high for 15, 20 years. For 15 or 20 years, I hear eHealth is on the brink of breaking through. Yesterday and today, on the brink of breaking through. The added value of eHealth for quality, for affordability, for accessibility, efficiency, safety, the potency of eHealth is incredible. It's going to save us. In my country, probably also in the Nordic countries, Netherlands is probably the southernmost Nordic country, but our policy has been very much supportive of eHealth as well. These were some policy objectives a few years ago. We monitor or the government monitors the progression in time with regard to eHealth. We do that with the eHealth monitor, and we see what the implementation, what the status of the implementation of eHealth actually is. And these are, a few months ago, the last monitor was published. It is published every year. It's an assignment of the government. And these, if you read this, it's incredibly open door. This could have been written 5 years ago or 10 years ago. Many opportunities for eHealth, please. And this is actually illustrative for the status of eHealth. The scale is still very low. There is 1,000 flowers are blooming, but upscaling, scaling up effective eHealth interventions is really, really hard. This is only one example. I could give you many more examples. This one is with electronic health records, but also with regard to self-management and other eHealth issues. You can see here that, well, if you study this, the exchange of patient data between my general practitioner and the hospital is still very low. And the hospital and the doctor, they are still doing good, but the doctor and youth care, mental health care, social services, police, well, that doesn't work at all. Okay. These issues of low adoption, I'm sure you recognize them. And we have analyzed them over the years. What are the causes for this low adoption? What are the causes for this poor implementation of very intelligent solutions? Well, we see that there are financial issues. When is an intervention insured care and when not? Young and bright innovators, they invent something and do not ask themselves the simple business question, if my intervention is going to work, who's going to pay for it? Okay, financial issues, standardization, interoperability. Still a big, big, big issue in the Netherlands. Hospital systems that don't work together. Also unfamiliarity, both among professionals. Professionals do not dare to advise an app or a specific home application because there's lacking evidence or because they fear for legal consequences. Also consumers, patients, do not know so much about eHealth. Okay, I've told a little about the entrepreneurship, lacking business model. Business modeling in health is really hard because successful eHealth often means a loss of production. Who wants a loss of production? Not a hospital, There are intelligent economic models for that, shared saving models, social returns on investment, etc. I'd like to speak with you later on, probably more in depth with it. I will be here to connect. And of course, the evidence base. We need more evidence to convince people to pay for new interventions. And this is a standard recipe we hear from all kinds of organizations. The government in the Netherlands has awareness campaigns for both professionals and for consumers. There's always a call for more implementation research, but I'm a bit tired of more and more research. We know what the implementation issues are. We really have to start working and to use effective interventions in implementation. And that brings me towards the concept of appropriate care. Maybe you have heard of appropriate care. It started as a movement in Canada, I think, United States, UK also, choosing wisely. We can observe worldwide that about 20% of the total healthcare volume costs is spent to needless care, wasteful care, unnecessary care, which is called overtreatment. Overtreatment with ineffective interventions. Both in the diagnostic stage, too much clinical chemical testing, both in surgery, uterus taken away, knees replaced, ankle replacement, whatever, and too much medication. Diagnostics, surgery, and medication. Overtreatment. It sucks. It's not ethical at all. People say, well, if it doesn't damage, but it sucks. I mean, it costs a lot of money, and it damages patients. So, what can we do? This observation, there's a lot of if you Google appropriate care or choosing wisely, you find the answers to diminish wasteful care. And that is putting the patient central, patient included. I miss patients on the stage, actually, today and yesterday. But is it a quality defect, wasteful care? It means that the needs of patients do not meet what is offered by healthcare. That's the gap. That's the deficiency in care. Sometimes it's because of bad coordination. Sometimes it's caused by poor data exchange for patients. Your medical data, having them available for some people is a human right. And underuse of effective care, and the counterpart, overuse of ineffective care, which is more the case in low-resource countries, but which is a problem in itself. There are many, many, many examples of interesting, innovative interventions which cause medicalization. For instance, with gaming, when young people are drawn into care, being, everybody's a pre-patient, A doctor's joke is that somebody who is healthy is somebody who has not been searched well enough. Okay. So people, an example is ICD, which is a kind of sophisticated pacemaker. It's implanted to help with arrhythmic in the heart. And from research, it appears that there's a lot of false positives. So that as a patient, you get a signal that something wrong, but there isn't, causing a lot of unrest among patients. Patients lose their autonomy. They think they are watched for 24/7, but it's not the case. Sometimes only once a week, or there's a machine with algorithms watching the patient. This leads to overload of work among cardiologists. It may also lead to loss of autonomy. Okay, the answer to this is these are all repairable things. We make them, so we can unmake them. We can unlearn them, de-implement them. And that is the idea of appropriate innovation. When we start innovation, we should think about these questions. These issues you see here on the slide are actually they're from industrial engineering in the 50s and the 60s in Japan and in America, lean management, Six Sigma, etc. You look at the healthcare industry as a processes of delivering care in an important position of the patient, and you have to understand the problem. Your innovation, what problem does it answer? You have to be analyzing the system permanently. And you choose the instruments for change, and you measure the impact of change, because measurement is convincing. You have to convince the insurers, you have to convince the hospital board, and you have to convince the patients and the providers to deliver this innovation. Okay, I have 0 seconds left, and this is my last slide. This is comprising some ideas. E-health is just health. As an example of innovation, it's a good example of a country like yours, where all social and technological conditions for successful e-health are there, and still implementation doesn't work. How come? Okay, we have to start with a patient-included approach, quality first, effectiveness first, measure, 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 and keep in mind that these new interventions, these new innovations should not promote over-treatment, but should promote appropriate care. Thanks.